Good morning. Thank you for joining us today. My name is Joan Williams. I'm one of the foot and ankle surgeons in the Department of Orthopedic Surgery here at UCLA. And I'm going to be talking to you today about common sports injuries in the foot and ankle. During the webinar, feel free to ask any questions via Twitter or Facebook using the hashtag UCLAMDChat. And I'll try to get to most of those, if not all of them, at the end of the webinar. So today we're just going to go briefly through some of the most common injuries that I see in the office for people who are active. We're going to talk about Achilles, ankle sprains, stress fractures, heel pain, and we'll just kind of go over brief symptoms, how you treat them, and when you should see a doctor and when you should just give it some rest and some time. So we'll start with the Achilles. The Achilles tendon is the largest and strongest tendon in your body. It runs from the back of the knee down to the heel. And so you can get pain when those are involved anywhere along that area. Tendonitis is just inflammation around the tendon. You see it a lot in people who are runners, jumpers, anyone who is having that kind of repetitive activity to the leg where they're trying to push off or deal with hills, stairs, anything like that. The main risk factors for this are things like overuse, so people who only do one type of activity are more prone to it. Age, unfortunately, as we age, we just don't heal as well. Poor shoe wear, meaning if your shoes are really old and worn out or they don't have a supportive heel, that puts more stress on your Achilles. And overtraining or training too hard, just various errors that way. There's two different types. There's insertional and non-insertional. The insertional tendonitis is where you get pain closer to your heel. So it happens basically where the Achilles meets that heel bone on the back there. The non-insertional is a little bit higher than that, so kind of just behind your ankle. Sometimes people get bumps on the back of their heel that you'll hear called any number of things. The medical name is called a Hagelin's deformity. People have called them pump bumps, heel spurs, any sort of thing. The bump is a reaction to how your bone develops and then the inflammation around the bone at the tendon there. And that bump can sometimes pinch the tendon every time it moves and just make the pain worse. So what you see is you get pain either in your heel or in the Achilles tendon along the back of the calf. It's usually worse in the morning when you wake up, and after you start moving, kind of gets a little more warmed up and a little less painful. It'll be aggravated by running, or if you're running on hills, you're doing a lot of jumping, anything like that. Occasionally you might notice that there's a little nodule in your tendon or it feels thicker than the other side. That's a sign of kind of chronic inflammation. And sometimes if it's gone on long enough, you can see that the calf gets smaller on that side or you feel weak trying to jump or push off. Treatment just depends. If it's something that's just started, initially, we'll try to rest it for a while, whether you go into a boot or just decrease your activity. Ice, things like ibuprofen, Aleve, anti-inflammatories will help take care of the inflammation and swelling. A lot of times there's physical therapy involved, which works on stretching and strengthening the calf muscle and the tendon. And then it's usually a gradual return to activity, which I think is the toughest part for people. As active people, we like to get right back out there, and really what's going to help you is kind of easing back into whatever your physical activity of choice is. And then if all else fails, there is surgical treatment for this. Achilles ruptures are fairly common. They're different than the tendonitis. This is where the tendon actually tears in half. We see it a lot in our 30s to 50s. It's sometimes can be caused if you get cut on the back of your leg from some accident or something like that. But most often it's a force on the tendon when you're trying to push off. The most common story I hear is people were playing basketball or running or doing something, and all of a sudden they feel like they got kicked in the back of the leg or they got shot in the back of the leg or something happened without necessarily anyone contacting them, and they had pain in that calf. Risk factors for this are if you have any inflammatory issues like rheumatoid arthritis, you're a little bit more prone to this. Taking certain antibiotics can make the tendon prone to this, and steroids as well can weaken the tendon. About 10% of people will have pain in their Achilles prior to actually rupturing this, but it's somewhat rare. So, like I was saying, most people feel like they got kicked or hit, and they'll have pain initially, and then a lot of times the pain goes away. And what they notice is they feel weak trying to walk. A lot of times these get kind of missed, and people think it's ankle sprains because they're able to walk and the pain gets better. So if you have any of these feelings and you're worried about it, it's usually better to get checked out sooner rather than later. An exam, you don't necessarily have to have an MRI or an ultrasound to diagnose these. It's diagnosed by a physical exam where the doctor will squeeze the back of your calf and see if your foot moves. If it does not move, that usually means that the tendon is ruptured. You may feel a gap in the back of your tendon, or you'll just notice that you're very weak when you try to go up on your toes or point your toes. Historically, this used to be an injury that was always treated with surgery, just because the results in terms of how much power you had in getting back to activity and the risk of re-rupture was much lower with doing surgery. There's been a shift in that to where we're now treating a lot more of these without surgery, because we've done studies that have shown that getting people back to early functional rehab actually has just as good of results as surgery, and you don't have all the risks of infection and wound healing problems that you can get with surgery. So based on, usually whoever you see will have a discussion with you about this, and based on what you think is the best decision for you, kind of decide your treatment from there. So moving on to ankle sprains. This is by far the most common sports injury and everyday walking around injury I think that we see. 10 to 30% of people will continue to have symptoms that we call chronic, which persist after kind of the first couple months of the ankle sprain. Those are things like pain, swelling, instability where your foot just kind of gives out on you when you're walking or you try to do any activity. But if you have a really bad sprain initially, that doesn't always mean that you're going to have chronic symptoms for life. Most of these will get better with time. So what we're talking about in this is common ankle sprains. You'll hear about high ankle sprains that a lot of athletes have. That's a different set of ligaments. Today we're just talking about the ligaments that are on the outside of your foot, which are a set of 3 ligaments. My pointer's not showing up on there, but the ATFL is the one that's most commonly torn. So that's what you think of when you hear that someone sprained their ankle. There's different grades of sprains, and this is usually used for us as physicians to kind of determine your prognosis and how to treat you initially. Grade 1 is just where the ligament is stretched. Usually you're able to walk a little bit, it's just a little sore. Grade 2, there's a partial tear in one of the ligaments. Again, you can walk, but you're limping much more. And then grade 3, there's a full tear and it's really hard to put weight on that leg initially. Most of these always get treated with non-operative management initially. And so some people will put patients in a cast for a few weeks, some will just give you a boot or an air cast. If it's a grade 1 sprain, you usually just need kind of an ankle brace. Things like rest, ice, compression, and elevation, the things you've probably heard since you were younger as playing sports, are usually things that will help with the swelling and the pain. And then physical therapy can help regain the balance and the proprioception. And most of what we found is that at least 10 to 12 weeks of physical therapy is what's required to get the maximum benefit. Like I said, most of these will heal within 6 months, and you really only need an MRI if you're having issues such as recurrent swelling and recurrent pain to rule out any other sort of injury to the cartilage or the other tendons around the ankle. Stress fractures. are things that are very common in people who kind of all of a sudden start their activity, or have a sudden increase or change in what they've been doing normally. What these are stress reaction in the bone that, if it goes on too long without rest and treatment, can become a real fracture where there's an actual break in the bone. There's a few bones that are more prone to getting this, and that just depends on the blood supply of the bone. So where we see them most tends to be in the tibia, which is your shin bone, kind of around your ankle, your heel, and in your second metatarsal, which is one of the bones in your foot. X-rays, a lot of times, if you go and see a doctor and you get an X-ray, they're probably going to be normal. It usually takes up to a week or more for signs of stress fractures to show up on an X-ray. So if you're really concerned and unsure of the diagnosis, a lot of times we'll get an MRI just to see if there is any actual stress reaction going on in the bone, because that will show it a lot earlier. Again, this is usually seen in people, runners, dancers, people who are doing kind of the same activities over and over, and putting a lot of stress on their feet. It starts as pain, and a lot of times the pain kind of starts only with whatever activity you're doing, and a lot of times it's towards the end. And then as it gets worse or the stress reaction builds, you'll start noticing that the pain is there at the beginning of that activity, and then as it goes further, it may be there every time you walk on it, and when it gets the farthest, it's usually there even at rest. So if you notice that you're starting to develop this pain, and it can be pinpoint to kind of one area that feels like it's on the bone, and the pain is getting worse and more persistent, it's probably worth seeing a doctor sooner rather than later, just to make sure that there's nothing like a stress fracture or a real fracture going on. Treatment for most of these is to put you into a cast or a boot or some form of support and keep you off of the foot for about 6 to 8 weeks, depending on where along that spectrum of symptoms you are and which bone it is. There are newer studies where people are giving vitamin D or bisphosphonates, which are often a type of medication that are used for people with osteoporosis, to help heal the fractures and make the bone stronger to prevent this from happening again. We don't usually do that right away, but if you're having trouble healing something, or you have a little bit of osteopenia or osteoporosis, that may be something that we consider doing earlier. And then again, like all of these injuries, when you return to activities, it's going to be kind of a slow and stepwise thing. And the last topic we're going to talk about, although certainly the most common topic I see in the office, is heel pain. Heel pain can be due to a lot of different things. Plantar fasciitis is probably the #1 thing and what most people think of. There's also a nerve that runs along there that can sometimes be getting pinched. You can have a stress fracture. And unfortunately, as we age, the fat underneath our heel, which cushions our foot, starts to thin out, and that means we're walking more on the bone, which can be very painful. Today we're going to focus mostly on plantar fasciitis because, as you can tell, it's very common. It affects up to 2 million people a year. It's usually, unfortunately, between our 40s and 60s. Rarely do people have it on both feet. A lot of times when you have it on both feet, it's because of some other systemic issue like rheumatoid arthritis or another inflammatory arthritis that just makes the body prone to this inflammation. Again, it's seen in people who are kind of constantly putting a lot of strain on their foot, whether it's through running or jumping, or even just having jobs where you have to stand for long periods of time can put extra stress on your foot. The risk factors for plantar fasciitis are things, weight. As long as we can keep our weight down, that keeps a lot of stress off of our joints and our feet especially. Decreased motion at the joints in the ankle and below the ankle can put a little bit extra stress on the plantar fascia. Having tight calf muscles, because your calf runs down to your heel and then the plantar fascia goes from the heel to the toes. So it's all kind of connected, and that can put extra stress on your plantar fascia as well. Unfortunately, age is not always friendly to us in terms of healing our injuries, so that is a risk factor. And poor footwear is a risk factor as well. So as you can see in the diagram, you can get pain anywhere along the arch of the foot. I think the most common is to get it right below the heel, although there are patients who come to see me and have it more in the arch or more in the ball of their foot as well. Usually people get pain in the common complaint is it's pain right when I step out of bed in the morning, it really hurts, or after I've been sitting for a while and I stand up, it really hurts. And then as you move around, as you kind of stretch things out, the pain tends to go away. The reason for that is when we sleep with our feet pointed down naturally, and that just causes the plantar fascia to contract. And so when you stand up or you get up in the morning and you step down, that plantar fascia has to stretch out again. And if it's irritated, it's going to be really painful. Like I said, you can see pain anywhere along the bottom of your foot. Typically it's right under the heel, but it can be through the arch and in the ball of your foot as well. If you pull your toes back towards your head, sometimes that makes the pain in the arch of your foot worse. We'll usually get x-rays just to make sure that there's not something like a stress fracture or other reason for you to have pain. A lot of times you'll see these heel spurs on the x-rays. That heel spur, again, is not necessarily causing the pain. It's a reaction to having inflammation where that fascia inserts on the heel, and the fascia and the bone kind of calcify together with chronic inflammation over time. If you get an MRI, it usually shows that the plantar fascia is a little thicker, or there's some swelling or edema in the plantar fascia. Again, the good news is that 90 to 95% of patients get better without any sort of surgery. The bad news is that can sometimes take up to a year, and this is an annoying problem to have. I have had it because we like to be on our feet, and everything we do involves standing up. It is a pain in the butt to try to treat and deal with when you have it. The way we typically treat it is rest. So if you get it because you've been doing a lot of a new activity, we try to cut back on that. Ice, anti-inflammatories, again, help with the inflammation. Massage therapy has been shown to be very good for this, as well as physical therapy to help strengthen and stretch all the muscles around the calf and the ankle. Keeping your weight at a healthy level will always help all of your joints and your feet. Sometimes you need some orthotics to give some support to that arch. And then occasionally, if you're having a real tough time getting rid of this, we'll recommend getting some night splints. And that's what you see in this bottom picture here. You wear it at night to hold your foot up so that that plantar fascia stays stretched through the night, and so that in the morning you don't have as bad of pain when you wake up and start walking. Not everyone can tolerate sleeping with them, but they do work very well. So if you can tolerate it, it might be a good thing to try. So in summary, I know I went through that quickly. The majority of injuries we see from sports in the foot and ankle are kind of overuse type injuries. It's from repetitive loading of your foot, repetitive activities that put a lot of stress on the foot. Every once in a while we see an Achilles rupture or a bad ankle sprain from a fall or a contact sport. But I would say the majority of people who come in with kind of aches and pains around the foot and ankle are just from a lot of overuse on the foot. Most of these will resolve without needing any sort of surgery. It's unfortunately just going to take some time. But if you do have an injury where you can't put any weight on the foot, if you've twisted it really badly and within a day to 3 to 4 days it's not improving or the swelling's not going down, or you feel like you have a gap in your tendon or there's a lot more swelling than you would normally expect, that's usually when to see a doctor sooner rather than later. For most of these, if you try to rest it and give it a little time, you're not going to cause major long-term damage, but you don't want to sit around with a painful foot for more than a week or so before seeing someone and making sure that you're doing all the stuff you can to get back out there as soon as possible. So that's it from my part, but I think we might have some questions here. Okay. So the first question is, when is it necessary to opt for surgery for an Achilles rupture? This is kind of a tricky question. I wouldn't, if you're a professional athlete, that's usually when they go straight to surgery. If you are an everyday kind of active person and you don't have any risk factors for wound healing problems or infection, which would be smoking or diabetes, whether or not you choose to do surgery is completely up to you. Surgery does have a slightly lower risk of the tendon re-rupturing, and it's a fairly common procedure. The main risks of surgery are infection, wound healing problems, and there's a nerve that can get irritated. These are all fairly low risk, but they are the risks of going into surgery. Non-operative treatment has a slightly higher risk of re-rupture, but it doesn't have the risk of infection and nerve injury. And both treatment options have been shown to have very similar outcomes in terms of how much power and strength you regain in that Achilles. It's always going to be a little bit weaker than the non-injured side, but you can get back to activities with both types of treatment. It really just kind of depends on what you feel is best for you and your life, what kind of recovery you want to go through. Okay, so the next one is, being the strongest tendon, does the Achilles heal better than other tendons with rest and self-care? I don't think that because it's the strongest tendon, it necessarily heals better. The problem with tendons is that they just don't have a really great blood supply. So within all of our tendons, there's usually an area where the blood vessels are coming from each direction, and where they meet, there's a little defect in how good the blood supply is there. So that area always tends to be a little weaker. And there's what we call a sheath around the tendons, which does provide some blood supply and nutrients to the tendon, but it can also get injured with age and inflammation. So all of the tendons heal fairly similarly. So unfortunately, just because it's the strongest, I don't think it necessarily heals any better. But okay, and I think that is it for all of our questions. Thank you very much for joining us today. If you have any further questions, you can always contact me via our website at UCLA Health. And hopefully we'll get you back to activities soon. Thanks.